I've spent the last 30 years searching for the cause and the cure of scleroderma. And I'm going to talk to you a little bit about research. There is, of course, basic science research. Let's see. Yes. And what I'm going to talk a little bit about today is genetics. This is what I've spent the last several years in my research lab doing. And then I know that many of you in the audience have participated in the skin biopsy gene expression studies that are done here. We are also doing them in Texas, and this is a very promising area of research. And then there's also an area that's trying to look at blood or biomarker studies. It would be wonderful if we could just do a blood draw and identify which patients are going to do well, which patients are going to progress, etc. But right now we're not there. We have to do a skin biopsy because still that's where the money is, in the skin. And then there are that's basic science research, and then there's the clinical treatment trials. There's the single center proof of concept trial that looks at a particular drug, and if it seems to be beneficial, then it will go into a wider multi-center controlled clinical trial to establish that yes, it works or no, it doesn't work. So let's talk about what causes scleroderma. And I will, in case you have to leave early, I'll give you the punchline now. We don't know, but we know a lot more now than we did 30 years ago. And there's the genetic predisposition. So one question is, does scleroderma run in families? And for the most part, when I'm in clinic and I'm seeing a new patient and I say, does anybody else in your family have anything like this? And they'll say, no, I never heard the word before, I didn't know how to pronounce it, and in Texas people pronounce it in lots of funny ways, but nonetheless, it does not apparently run in families. Does anyone here have a family member who also had scleroderma? Okay, well that is relatively unusual, but what got me, and then that question led to the scleroderma registry and DNA repository, and I think your DNA is probably in one of the slides that I'm going to show a little later, but this is a National Institutes of Health sponsored study to look at susceptibility genes in scleroderma. And this is a family that I saw when I first was in Michigan quite some time ago, and this is a family pedigree. So here are the parents, and the circles are women, the squares are men, and these are their 4 children, a daughter and 3 sons. And the yellow means that these are scleroderma affected individuals. This, the older brother, so it goes, this is the youngest and then all the way up to the oldest. But this individual has limited scleroderma. He was diagnosed in 1995, and his younger brother was diagnosed a year later at the age of 16. This one, the older brother, was 22 when he was diagnosed, and their disease was very similar, both in terms of clinical distribution, because they were both limited disease, and also in terms of the autoantibody. ANA was positive in both of them, SCL70 was negative, and this is an unusual family in that there are 2 boys who were affected, young men, when they were diagnosed, and is more commonly seen in women than in men. And it is unusual in that it runs in families, especially first-degree relatives, to have a parent or a sibling or a child affected. And then this is the other kind of family that we see when we do these family studies. So again, and this arrow means this is the patient who first came to my attention. She has scleroderma, and she said that her mother had scleroderma. Not only that, but her uncle. So this is the grandparents of my patient who are deceased when I first saw her, and her mother had had scleroderma. The mother's brother has lupus. The brother has 2 daughters. This daughter has lupus. This daughter has multiple sclerosis. So this is a family in which it's not just scleroderma that seems to run in the family, but multiple autoimmune diseases. So So one would expect that there are different sets of genes. One sets you up for autoimmunity, and the others tend to put you down that avenue toward a particular autoimmune disease, such like scleroderma or lupus or rheumatoid arthritis. So that brings us to the next question: what genes are involved? And if this is the DNA helix, and the DNA, of course, is the music of life, so you ask the question, what genes? And here are the possibilities. Everybody has 46 chromosomes. You get one from your mother, one from your father, and each of the chromosomes have hundreds, if not thousands, of genes. And we started collecting samples in the late 1990s because in order to do these studies, you need thousands of patient samples and thousands of controls. And in 2001, this is a summary of all of the genome-wide association studies that had been done to date. And there aren't 23 chromosomes here. These are just the ones that have been identified or had been identified with autoimmune diseases. And then if you look fast forward to 2009, these are the chromosomes again, and each one of those circles represents an area of the genome that has been associated with autoimmune diseases. And now in 2010, we published the first genome-wide scan of scleroderma patients, looking at 2,300 scleroderma patients and over 5,000 controls. And this is the slide that I believe some of you may be represented in. You may be one of these tiny little dots down here. So here are all the chromosomes. And then this is the frequency of the difference between cases and controls. And you see that there is a peak here in something called the HLA region. And then there are also other peaks around here. We identified 4 or 5 genes that are very strongly associated with scleroderma. So the next question, what are those genes and what do they do? Since 2010, we've also done additional scans looking at autoimmunity genes. And when I started out and started as a clinician, it seemed to me, at least in the office when I was seeing patients, scleroderma was very different from lupus, and it was very different from rheumatoid arthritis. Lupus patients had skin rashes that came and went. Scleroderma patients have skin thickness, fibrosis in the skin, fibrosis in the lungs. Clinically, it is a very different condition than lupus or rheumatoid arthritis. But then, one of the things that surprised me when we did our first genome-wide scan was that there are a lot of genes that predispose to scleroderma that are in common predisposing factors to lupus and other autoimmune diseases. And this is probably why we see those families in whom multiple autoimmune diseases occur. And over here, sort of on the pink side, are all of the immune-related genes, interferons, interleukins. These are the signals that will tell one white cell to activate another white cell. And then there are just a few genes that are related to fibrosis and just a few genes that are related to the vascular damage, which was surprising and is surprising to me. The next question is, so you have these gene variants. What does that mean? If you have an unusual combination of genes, what is that really doing to the immune system in making it overactive or underactive, misinterpreting immune signals? Well, the kind of genes that we saw, immune function genes, now about 30 genes scattered among the chromosomes. Many of them are shared susceptibility genes with lupus and rheumatoid arthritis, but having the right combination of genes, or perhaps you could say the wrong combination of genes, is not sufficient to cause the disease. you also need some kind of external trigger or initiating event. And usually the first thing that happens in scleroderma is Raynaud's phenomenon. Then that's followed by puffy, swollen hands, and that's followed by skin fibrosis, which can occur with internal organ complications. Usually, but not always, in this sequence. And of course, I don't need to show this to you. I'm not sure how well it projects, but this is the sort of purple or cyanotic phase of Raynaud's phenomenon. And this is the phase of pallor, and the fingers can, at the same time, be purple, and another finger can be pale, and then it sort of goes back and forth until people can warm up enough so that the hands return pretty much to normal. So why do you get Raynaud's phenomenon? Or what is it? It's a spasm of the small blood vessels, which is an exaggerated response to a cold challenge. There's something called primary Raynaud's, common in the general population, perhaps 5 to 10%. Different studies have given different estimates. It's common in US adults. It's perhaps 10% of all women in the US at some point will experience Raynaud's phenomenon. Maybe 5% of men. It's more common in women. But certainly 10% of the adult female population does not have scleroderma. That's primary Raynaud's. It will always stay primary, never develops into anything else. And then secondary Raynaud's that occurs with scleroderma and less frequently, but still occurs with other autoimmune diseases as well. So if we start out with Raynaud's phenomenon, why do the hands get puffy? The same kind of thing that's happening to cause Raynaud's, that spasm of the small blood vessels, is due to blood vessel damage, and it's in those tiny little blood vessels, not throughout the body. At the same time they're damaged and they're causing Raynaud's, they become somewhat leaky, and serum moves out from the blood vessels into the tissues, usually in the hands, sometimes also in the feet. But as the blood vessels become more damaged over time, they become less leaky, the hands are less swollen, and the skin gets thickened. So that's sort of the consequence of what's happening pathologically in scleroderma. So what causes the skin to get thickened? And that is increased collagen in the skin. The collagen is made by skin cells called fibroblasts. They tend to be in the deeper layers of the skin. And in normal conditions, the fibroblasts are there to produce collagen if there's a break in the skin. So you get scar formation. That's normal. And one of the problems in treating scleroderma is that it is unwise to stop. We can stop collagen production. The problem is that the mice die because you need the ongoing collagen production in order to maintain normal consistency of the skin, or if there is a scar either in the skin or in internal organs like with pneumonia in the lungs, you need the scar formation in order to heal that. But in scleroderma, the fibroblasts are activated spontaneously, and they remain activated. They don't go away the way a normal activated fibroblast will if there is some sort of insult to the skin or the internal organs. So, speaking of internal organs, it's this increased collagen that causes the scar tissue and fibrosis, and if it happens in the lungs, it's called pulmonary fibrosis. If it happens in the heart, it can interfere with the normal electrical conduction system in the heart, or cause damage in the heart muscle itself. And if there's increased collagen in the GI tract, like the esophagus, it interferes with normal motion. And if there's blood vessel damage interiorly, then there can be decreased circulation to the kidneys, causing high blood pressure and renal crisis, or in the lungs to pulmonary hypertension. So not all of these things happen in every patient. And that's one of the mysteries in scleroderma, is that most people start out with Raynaud's, then puffy hands, and then some skin thickness of the fingers, and some people stop there and don't go on to get other internal organ involvement. Usually in the first 5 or 10 years, the internal organ involvement will start to develop, but in some individuals, it does not progress, and the only thing that tends to happen late in scleroderma is this thing called pulmonary hypertension, where finally the blood vessels in the lungs become involved. And what predisposes people to get that as opposed to other forms of scleroderma is very unclear, and it remains, even after 30 years of study, a mystery in many ways. So what's the role of the immune system? We've been talking about the vascular system and collagen and fibroblasts. Well, how does the immune system play a role in all of this? And usually the immune system is there to fight off external invaders, bacteria, viruses, that sort of thing. But in autoimmunity, the immune system can no longer distinguish self from non-self. The immune system can recognize bacteria and viruses as non-self and attack them. It doesn't attack its own tissues. In autoimmunity, that barrier of self-tolerance is broken. And in scleroderma, the immune system damages the blood vessels, and that sort of drives these skin cells, the fibroblasts, toward activation. Well, there are dozens of different types of immune cells and hundreds of soluble immune factors that all come to play in this. So we talked about the genetic predisposition and external triggers, and then there are persistence factors, and this is probably why some scleroderma patients will start with scleroderma, the Raynauds, the skin thickening of the hands, and kind of stop there, whereas others will progress to internal organ involvement. And to talk a little bit about the skin biopsy gene expression studies, and to distinguish it between the genetic studies that I first talked about, because every cell in your body contains every gene, all 25,000 genes, but not all genes are turned on in all tissues. The skin of scleroderma patients have different genes turned on than the skin of healthy controls. The gene expression patterns can tell us what pathways to target, what pathways that are turned on that we can then turn off in order to get the scleroderma skin back to normal. And with that, medication that should get skin back to normal should also get the lungs and other organs back toward a more normal functioning level. And I'd like to talk, since the topic of this is research, to talk a little bit about clinical treatment trials. So how many here have taken part in a treatment trial? Yes, several, and thank you. We are all very indebted to you for your participation, and I'm sure that most of the subjects, or most of the scleroderma patients in the room have given a skin biopsy, but how many non-scleroderma patients here have given a skin biopsy? Oh, I know myself, I know Dr. Yes. This is one of the unusual situations when your friend or spouse takes you to the doctor or accompanies you to the doctor, and I turn to them and say, you know, you could help us in research. You could get your blood drawn, you could get your skin biopsy done, and they're usually too embarrassed to say no. But anyway, but my point is we need the controls. The controls are just as important as the cases because we need to be able to compare the scleroderma cases from the healthy controls. So clinical treatment trials, this is a place where we don't have healthy people participating. And the question is, why do we need controlled trials? You can either have standard of care trials versus your new agent, or placebo-controlled trials versus your new agent. And one of the problems in scleroderma is that the skin in scleroderma tends to slowly improve over time, even without treatment. Some patients never get significant internal organ involvement. And even those with internal organ involvement, sometimes it stabilizes on its own and doesn't continue to progress. So we need to have a comparison group who are on, say, standard therapy to compare with those who are on the new therapy or the experimental therapy. And this is a quick tour through the last 30 years of clinical trials in scleroderma. And this is for fibrosis, skin or lung fibrosis in scleroderma. The D-penicillamine trial was the first one that I was involved with, and the first time we really did a large multi-center trial. And then there was a photopheresis trial, methotrexate, interferon, relaxin, collagen, TGF-beta, BILD2, the lung study, and then the new studies on the high-dose chemotherapy and stem cell transplant. But in terms of what happened to in all of those trials, well, the penicillamine trial was negative. It was very well designed, nicely done. It just showed that there was no difference between the people who were on penicillamine and the people who were on placebo. The photopheresis trial also failed to show an effect. The methotrexate trial, there was not much of an effect on the fibrosis, but there was an effect on the inflammatory features, tendon friction rubs, joint pain, and other inflammatory features. That's the interferon was negative, as was relaxin, and the collagen tolerance and TGF-beta and the BILD2 trial. And now this is 30 years of doing these clinical trials, and finally we had a truly positive trial looking at the progression of lung disease called the scleroderma lung study. There was a significant difference in both skin scores and lung function in the people who were on the true drug and the people who were on placebo. The only problem with that is that the drug was cyclophosphamide, also known as Cytoxan, and the reason that there is tox in the name is that it is a toxic drug therapy. It has to be very carefully monitored, and there's potential for severe side effects, although I certainly use it in a lot of my scleroderma patients who have progressive lung disease. And then the ASTIS trial was also a positive trial. That's the European high-dose chemotherapy stem cell transplant trial. There is a US trial that is still ongoing. We have enrolled all patients, but we're following them for a period of 5 years because we want to answer the question not only does it help, but is the improvement persistent? So does the disease come back? Does it worsen again? Because we feel that if people are 5 years after treatment and continue to do well, that they are likely to be long-term improvers. So the current ongoing trial, since the lung study, the scleroderma lung study 1, looking at cyclophosphamide versus placebo, that was positive. Our next question was, is there another drug that's going to be as good as the cyclophosphamide or Cytoxan and not have the same kind of side effects? And the drug that we are testing is mycophenolate or Cellcept, which is in common and fairly widespread use in scleroderma. I think it's effective, but the question is it better or worse or the same as cyclophosphamide? We've enrolled everybody into this clinical treatment trial. It's a multi-center trial, and we're following people along. We should have an answer in about another year. And then there's the Scott trial that I mentioned that's ongoing. There is another trial looking at an rheumatoid arthritis drug, rituximab, in scleroderma pulmonary hypertension. And there are multiple other trials that are ongoing, both proof of concept trials at a single center looking at either a new drug or a drug that's currently approved for other indications that, because of theoretical reasons and the science behind it and how it affects the immune system, there's a good rationale that it might also be effective in scleroderma. And one of the gratifying things I find is when I started out 30 years ago And a small group of us got together and said, let's see if penicillamine really works. This was a group of 6 people. We were meeting around, all right, a table in a bar. And somebody got out a napkin and said, okay, here's how we can do this study. And we outlined it on the napkin. And then a few years later, with NIH funding and formal protocols, we finally got the study up and running. And the bad news, the D-penicillamine trial was not effective, but it organized the scleroderma physicians into a treatment trials group that gave us the infrastructure to do these trials, and eventually got pharma interested in supporting them as well. Well, let's look at the causes of scleroderma, what we know and what we don't know. We know that some genes increase susceptibility, but genes are not enough. And in addition to having little scars on my arm from serving as a normal control in skin biopsies, my blood was also part of that big genome-wide study, as I serve as a normal control for that. And as part of that, I found out I have the risk gene for CD247, which is an immune kind of gene. But fortunately, I don't have a combination of the other genes that result in scleroderma, but nonetheless, many people who are healthy controls will have some of these gene variants. So just having the gene is not enough. The immune system becomes activated, small blood vessels start to narrow, the fibroblasts increase collagen production. But what we don't know is the external trigger that starts the process. And we also don't know the key points in the process that can be interrupted to stop the disease. And this is where scleroderma research currently is, trying to identify those pathways early in the disease that are key to causing the disease to progress. And if you could just interrupt that pathway, all of the downstream events could not take place. Well, there are multiple ongoing clinical trials, more than I've seen in the past 30 years. And that has resulted in a well-organized and collaborative group of dedicated scleroderma researchers. Also, an interest by pharma to tackle fibrosis in general and scleroderma in particular. I think the attitude of the big pharmaceutical companies several years ago was, don't touch scleroderma, don't go near scleroderma, you're just going to waste your money, nothing works, it's a fibrotic disease, don't invest in it. And since the scleroderma lung study, when we showed that cyclophosphamide was helpful, pharma started to take an additional interest and say, well, maybe something can be done. Here is a group of patients, here is a condition for which the field is wide open, the market is wide open, because we don't have even the first drug that has been shown to significantly decrease activity and progression of the disease. So that is one of the sort of good benefits that has resulted from the past many years of scleroderma research. So what can you do as patients and family members, friends, loved ones of patients? Well, learn about the disease, which is what you're doing now. Keep track of your test results. This is something I insist to my patients when they come in and say, well, I had pulmonary function tests about 6 months ago, and my doctor told me they were okay. No, get a copy. I want to see those numbers. Ask questions, which you'll have an opportunity in a few minutes to do, and I know that the Scleroderma Center here encourages people to ask questions and really learn about the disease. And as you've already demonstrated, to participate in research, because it is only through the cooperation of people like yourselves that we're going to be able to solve this disease. Okay, well, I think that's it.